Hi everyone, and welcome to Digitodontics webinar series. This is Mahmoud Al-Bishti with you today from the Digitodontics International Academy. It's my pleasure to welcome our guest speaker, Dr. Eszter Semogy-Ganss from the Faculty of Dentistry, University of Toronto. Eszter will share with us her experience in digitally enhanced implant surgery. Eszter is an associate professor teaching stream at the Faculty of Dentistry, University of Toronto. She is also a director of the undergraduate dental implant training program. She is a prosthodontist and has an experience as a maxillofacial prosthodontist, which utilizes at Sunnybrook Health Sciences Center, craniofacial prosthetic unit, and uses her skills to help model complex facial prostheses for the patients. Her research and clinical specialties are focused on various topics, including biomaterials, comprehensive care, education research, oral pathology, cancer oral pathology, oral medicine, and prosthodontics. So once again, let me welcome Eszter, and she will, as I said, share with us her experience in digitally enhanced implant surgery. So Eszter, I think the stage is yours now, please.
Thank you so much for the very kind introduction, Dr. Al-Bashti. I will share my screen now. So hello, everyone, and welcome to today's lecture. As said, I'm going to talk about digitally enhanced implant surgery, and I'll give you a little bit of background as to why, how I got involved with this topic, and show you how I looked like 10 years ago. So I will claim that there's no financial disclosure. So even though I have worked with one of the navigation companies, and I actually did my master's thesis with them, but I do not get any financial fees from any of them. I still consult with one of them on a friendly basis, but I do actually not get paid. So when it comes to implant placement and digital enhancements, we all know who place implants that these days we really try hard to have prosthetic planning first and just build a house before we start planning the foundation, which usually involves some kind of imaging, CBCTs or spiral CTs if one works in the hospital. We will plan with there's a plethora of programs out there. Then we are going to hopefully place our implants in some fashion. And then if all went well and we are accurate, then we are going to place our restorations according to our first plan. And then of course, there's going to be some maintenance involved at the end. Now, what I'd like to talk about today is more the first four options and parts of implant placement. When it comes to implant placement, some people say that, oh, well, these days freehand or, as it's more fashionably called these days, mental guided implants are not accurate and they are not really adequate anymore. I would disagree. If there's a very experienced implant surgeon, there's more than adequate bone, and there are some teeth that will help you with the implant placement, with the angulations and the depth and all that. Freehand implant placement, eyeballing an implant, nothing wrong with it, right? So that is still a very good staple in our toolkit. Then we have our guides, and if you work with implants, you work with oral surgeons, there are more complex cases. It's usually a good idea to have at least an idea of where the teeth would be going. With one tooth, it's a little bit less important, as said, because these guides, laboratory fabricated, they have nothing to do with bone availability. It's just kind of a foggy idea where the ridge is. So this is a good indication, but this is by no means very, very accurate either. And then we have the static guides, and depending on which company you work with or which planning system you work with. Most of the time they are stereolithographic, or they can be milled or 3D printed these days. These are already better because they are usually based on imaging. So you can actually utilize your CT images, and you can plan those implants, first the restorations, of course, and then the implants according to where it should be placed, ideally with the best bone availability and best prosthetic outcome. And then what I'll focus on most today is dynamic guiding, which is pretty much kind of, I would say, like static guidance, only a little bit more super speed, and less gimmicky in the sense that once you have a machine, then you don't need a lot of things to actually do this, but you do have to have the machine, right? So you have to have one of these. On the image, you'll see the Navidan system on the left side, and this is the system I most worked with, and the XNAV system on the right side with green. And I'll also mention robotics a little bit at the end. So what exactly is dynamic guidance or navigation? I'm not 100% sure how experienced you are with these, so I'll give you a little bit of a rundown as to how this works and what it actually entails. So what this does is you take a virtual treatment plan that you have already planned on one of those systems, and again, it could be anything, and then you actually implement this in real time. So while you're drilling, and I'll show you some videos, while you're drilling, you can actually see on the patient's CT where your drill is. Now, you are not taking a CT while you're drilling, but with all kinds of complicated algorithms that please do not ask me about because I'm not an engineer or mathematician, but with all kinds of algorithms, these systems, the software is actually going to relate your patient to a CT image so that you can do all this in real time. And if you wanted to translate this, the way it works is you are going to have some markers on the patient called fiducial markers, right? And if you think of movie technology, we very seldom have blue people running around. So you can see on the, I'll try to make sure that my pointer is visible. Just give me a second. So you can see that, the actress has these little green dots on her face, and you have a camera, which means that the camera can actually capture these green dots and later translate it to her becoming blue, right? So you have the camera, which we do have on these navigation systems as well. Most of the time we use stereo optic cameras, so you actually have two so that it actually looks in 3D and not just in 2D. So you have your camera, then you are going to have your markers, right? And with these navigation systems, different systems have different markers, but most often you have some kind of, markings. The Navidan system works with black and white circles. The XNAV system works with hieroglyphics. Whatever it is, it has to be something that the computer and the software recognizes, right? And then you have to have some navigation skills, right? So it's great for the younger generations who grew up with all kinds of computer gadgetry, because you are actually going to look at the computer, not necessarily the patient, which is the major paradigm shift in this case. And you're looking at the computer and you have to move your hand according to how it is on the computer, which sounds simple. But if you change from maxilla to mandible or mandible to maxilla, then the movements are actually a little bit different because you just changed your view of perspective, right? So it takes a little time to get used to looking at the screen and translating that, if I push my wrist left, then things either move to the right or left or whatnot on the screen. So it definitely takes some practice. And then once we have the practice, then we need a map. Which is usually your plan. So you are going to plan that perfect implant position, and the system is going to do their best to navigate you to that perfect implant position, both horizontally, depth-wise, and even the angulation. And if all goes well, then hopefully you will end up with a nice, spiffy, perfectly placed implant, right? So how this looks like, this is the XNAV system. I really try to use both major systems that are available. And you can see that with the XNAV system, you have the camera, right? And you see that this is also stereo optic, so you have two of them. You see that their markers are a little bit different. They have these kind of little markings on them. And what's the scary part? I'd like to draw your attention to the fact that the surgeon is actually not looking at the patient while he's drilling, he is looking at the computer, right? So this is what I'm saying, is that this takes a lot of mental practice to trust the system that it is actually going to take you where it should be taking you. So you have the camera, you have the markers. This is the navigation window. So it shows you if you're in the right spot, if you have the right angulation, and then it also shows you the depth. Most of these systems even have a, like the parking on the cars, when you get too close to something like beep, 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 beep. And then when you get to the big beep, then you know that you're not supposed to go any further because the implant is at depth, right? So it's not only visual, it also has some sounds just to make sure that you are as safe as possible. And then to get to this point where you actually have the surgery, and why I think this is a little bit more useful or more ergonomic than static guides. And I'll have a comparison table in a minute just to show you why I think one is better or worse than the other. This is the old version, and some systems still use this. So I was kind of debating yesterday if I should keep this in or not. But because some systems still work with a reference splint or tag, I decided to show it to you, and then I'll show you the newer version that both Navidan and XNav use by now. But most often what happened earlier happens with some systems, you have some kind of a reference tag, right? So you make kind of like a splint for the patient. Most of the time, this is a thermoplastic material. You can do it chair side, so it actually doesn't take a very long time. And it will have some kind of a fiducial marker that you can see on the CT images, right? Then once this reference marker is done, this is a different version. This is the XNav one. Everything that's green, it's XNav, and everything that's gray and red, it's Navidan. These guys have nice color coding. So you see that these have actually a little holder that very often, again, they use some putty or composite resin. And then you can attach, there's a hole on the side where you can actually attach the marker that hangs out of the patient's mouth, or actually is becoming the person. So then you take the CBCT, which is not very painful, thankfully. And if there is one in the office or in the hospital, it can be done reasonably quickly. Then, of course, you have to have the images processed. You get your DICOM files, and then you turn them into the sectioned, the panoramic, and the 3D images that you will need for your planning purposes. Once that's done, you do your treatment planning, and you do it with these systems exactly as you would with a normal static guide, planning system. Then comes the major difference that you put the guide back. Again, this is the old fiducial marker registration. You put the guide back, and then you put something that has these black and white, or with the XNav, those hieroglyphics on them, which will tell the computer that now the patient, the guide that was in the patient's mouth when you took the CT in real life is here. So this is the first place where you actually tell the computer that if the markers are here, then the patient's canine incisor, God knows what, is exactly where it is supposed to be on the CT, right? So this is giving your computer the idea where the patient is. And this is what's going to translate that CT to real life, right? So this is step number one. Step number two, you have to tell the computer where your drill is, right? So then you're going to take another calibration plate, and all times the calibration plate was actually here. First, you see that there's this little pack here. So first you put the handpiece on there. So there's no drill at all. You just put the handpiece on there and you rotate it a couple of times. It takes about 5-10 seconds. It doesn't take a long time, which will show the system that this is where the axis of your drill bit is, right? So then at least you know which direction you are going with. Then you place the tip on one of these markers. You do the same thing again. The computer sees the markers, knows, because you see there's markers on the drill bit as well. And that means that the computer will know exactly where your drill bit is, not just the axis, but also the length of it, right? So that's why every time you change drills and you have different lengths, you have to recalibrate your drill tip, right? Just to make sure that you're at the right position. So this part is going to tell your computer where the patient is and how the CT relates to the patient. This part is going to tell the computer where exactly that your drill is, your implant drill is, or even the implant if you want to calibrate the implant. And once that's done, you start your placement, and you are going to be actually seeing how the drill goes. And with the different system, I'll show you how it goes. So this is the old version where you needed some kind of a fiducial marker on the CT to calibrate the patient to the images, and then you could do your implant surgery. And the fun thing is, if you listen to what I said here, and you don't really have a choice, you did. So the whole thing, if you have a CBCT in your office, and you are ready to do implant surgery, and you are reasonably proficient in actually planning an implant or more, you can do this in about an hour. So the patient comes in, you do everything, and within an hour you can have a guided implant surgery, right? Which is really nice. So when it comes to dynamic guiding and static guiding, right? Static guiding, what I mean is that you have these computer fabricated static guides, which are also very nice, very accurate, but somewhat cumbersome, right? And I try to color code this. It has nothing to do with the systems now. It's more of green is something that I consider beneficial, and red is something that I consider a little bit more cumbersome, right? So if you start with the static guiding, first of all, you have to make that surgical guide. In today's day and age, it's a little bit easier, because if somebody has a 3D printer, then, in the office, then you can actually have a reasonably accurate surgical guide. But, you still need to have the titanium sleeves and whatnot. So it still takes time to prepare these, even if you 3D print them. Some systems are implant system specific, some are not. So, most of them, thankfully, today are open, but there are still some you have to be mindful not to be too implant system specific. Once the guide is done, it's done. So if you realize that, you start drilling and you realize that the bone quality is not exactly as you thought it would be, or, maybe you have the CBCT with the trabecular bone wasn't exact, and you don't really think that's the best place for your implant, you can't change it. You're locked in, right? So you have one spot on the guide, or as many as implants you have planned. If you don't like it, too bad. You can chuck the guide in the corner, but unfortunately, you're not going to be able to change it considerably. Also, most of these guides have limited visibility, because you actually have the guide in the surgical field, right? You have to have it there to guide your drills. Because of this, and because the guide is actually on top of the surgical field, cooling is a little bit more limited. Although these days the guides, they try to make them a little bit more narrow in that area, but still cooling is more difficult than it would be if you didn't have a guide. The very nice thing about static guiding, which is kind of where the robotics is going towards, is that you don't actually have to have hand skills. And I mean that, right? I mean, if you have a hole where you have to put a drill and then you just have to move up and down, probably a hamster can do that, right? Because, I mean, there is once the guide is accurate and everything is good, you really just have to follow that pathway. So dexterity is not an issue with these. But because the guides are reasonably tall, and very often these specific drills are a little bit taller as well, the guided drills, in the posterior, it is very, very difficult sometimes to get these drills and guides and everything else in one place. Sometimes what I used to do is, like, I took the guide out, I put the drill, and then I put the guide in together with the drill, just to have enough space to get to the posterior. So, and not that I'm trying to be extremely biased, but you can see there's a lot of red in this column, right? When it comes to dynamic guiding, what's really nice is, once you purchase the machine, which is, again, that's a big buy-in at the beginning. But once you purchase the machine, most of the companies are actually quite cost efficient for the guides, or, the little tags or whatnot. So that's not going to be an issue. You have an option of replanning, right? If you are in the middle of surgery and you realize that your implant is not exactly where it's supposed to be, you can just go to your computer, change the plan within 2 minutes, and then you can have your new guidance position, which is really cool and really flexible. Most of these systems are open, so they will work with any implant systems. Let me run through the greens and then I'll talk about the reds as well. It is very easy to get feedback, right? Because if you can see things on the CT and you take your virtual burr, as in your normal burr, and you touch it to a certain tooth, and you in real life touch the tooth, but on the computer it looks like you aren't, you know that you're off a little bit and you have to calibrate again. So you actually have a feedback loop that gives you an idea if you're accurate or not accurate. You can irrigate, because there's no guide, right? So if there's nothing on top of the surgical field, you can see if you want, you can irrigate. You can do flapless surgery if you trust the system enough, because theoretically you see where you're going on the CT. Ergonomics, probably it's actually kind of the same, except in the posterior, because again, if there's no guide, no special drills, it's a lot easier to do the surgery. And when it comes to the disadvantages is because you have to work with a camera, and that camera has to see the trackers all the time, both on the patient and on the drill, right? So if either you or your assistant, you go with your head and suddenly you cover these trackers, you lose your navigation, right? So you have to be out of that field constantly, because otherwise the navigation stops. So that's an issue, and that's something that one has to learn. And also the learning curve, right? Because it's not easy. We are very visual people until robots take over, but we are very visual people, and we are used to looking at the tooth or at the field that we are operating in. We are dentists, right? But with this one, to trust the machine and actually, do the drilling there and actually staring at the computer, very, very difficult. And also, you have to remember the joystick, as in you have to remember how to place your wrist and which way what goes. And of course, this is not automatic. So you need your dexterity. You need to be a reasonably skilled surgeon to place these implants, because the machine is going to guide you visually, but it's not going to guide you physically, right? So I'd like to think that, there is a lot more advantages to dynamic guiding than static guiding. And for me, I think the biggest issue is actually the flexibility with it, that you can have the feedback, you can recalibrate, you can replan if necessary, and the fact that you can do it a lot quicker. So you don't need to print something just to be able to do the surgery. So when it comes to the systems on the market, I'm not saying these are the only ones, but these are the more common ones today. And Navidan, I'm talking to you from Toronto, Canada, so it's very convenient. This is the company I actually worked with. Then in the US, they have X-Guide, and it has been purchased a couple of years ago by Nobel Biocare. So they are a lot more, they have quite a bit of push. Navidan is still privately owned. There's another one that has a very different, and I'll show you a couple of pictures. It's kind of very curious. I ran into them at a conference a few years ago, and I thought it was very interesting. The mini Navidan system. It has been purchased by Straumann about 6 months ago, because they haven't really moved anywhere. So I'm very interested to see where they are going to take it with the corporate sponsorship. Then there's Enliant, which is a Vancouver-based company. And then there's another one, Iris 100, if you read the papers, from Taiwan. And there's another one from Australia. And there are more systems popping up, but I think this would be the most usual culprits if you look at the literature. And these are the three that I'm going to talk about. And I'll start with Navidan, because that's the one I'm most familiar with. And I'm going to tell you about the processes, how they work. And I'm going to show you what the tracking system is that they use today, both Navidan and XNav. So this is how the system looks like. It usually comes in a cart. It's very similar to all the others. It has the, it has the cameras, it has the computer, and it has a heavy bottom, because otherwise, it wouldn't be fun if it tipped over. But what's nice is that you can also just clip it together and you can roll it around. This is how it sits in my office as well. And then I mentioned that it has the Micron Tracker camera, which is a very, very accurate camera. Actually, I think they are just updating it now. It's used in neurosurgeries. It's used in ENT surgeries. If I'm not entirely mistaken, the accuracy of the camera itself is 0.2 millimeters at a 10 meters distance. So it's actually really, really accurate. So my baseline error was about 0.2 millimeters that came from the camera. And then you have some kind of a tracker, fiducial markers. As said, Navidan works with these X points, and you can see that they are reasonably far from each other. This is on a plastic plate so that it's not very heavy. And then you can also see that there is this little wire that is reasonably sturdy and is going to be attached to the little mouthpiece that you are going to make. And the most important thing that I have already mentioned is that the camera is the king. The camera has to see all the time. So it has to see the markers that are attached to the patient, and it has to see the markers that are attached to the handpiece, because otherwise you are going to lose your navigation. And this is usually how a setup looks like for surgery. Most of the time for the mandible, we use this marker that it's attached to the teeth, because the mandible moves. So you kind of have to make sure that whatever you attach to a patient moves together with the mandible. Otherwise, it would be a little bit difficult. And then you do have a calibrator, right? So this is the newer version that is going with the newer tracking system that is going to help you to tell the system where the drill tip is virtually, right? So the system is going to compute this for you. And really the calibration takes about 5 to 10 seconds. It's not really an issue in any of the systems. And then once you actually register the patient and the computer realizes that, if the tracker, the fiducial markers are here, then in real life translation, the patient is going to be virtually there. So it will hopefully give you a nice and accurate description. If not, you can again always recalibrate, because you can always double check. So these days what people do, and I have an XNav video, and I also have a little bit of video from Navidan. They are a tiny bit different. So what they do these days, instead of making a molded stand, because that takes time as well, they actually have a tracer, which is literally kind of like a ball burnisher attached to a marked instrument, like the fiducial markers. And what they do is that they tell the computer that I'm going to touch a couple of points on the teeth, and you say, okay, I'm going to touch the incisal edge of the central mandibular incisor, the canine, and the first premolar. And then you actually touch with this little ball burnisher in real life as well. And then the computer, with this outline and those points, can actually relate those points in the patient's mouth back to the computer, right? So you don't have to have any tracers on the CT. You do not have to have a stent. The only thing you need is a patient with, and very often they use some kind of composite resin to attach these trackers or fiducial markers. So what you need to have is a computer that sees these markers, sees those markers, and can relate those data points to a CT image that you marked as well, right? And this is kind of how it looks like, algorithm-wise, right? So you tell the computer that I'm going to look at these blue dots, and I'm going to go around the teeth a little bit more to give you more data. And the computer is going to find the best fit of these outlines to the dentition of the patient, to the hard tissues, right? So that means that you don't need any gimmicks. You just need to have the visibility from the computer, the cameras, right, that are connected to the computer. And once this is done, you just went with the ball burnisher, like blah, 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 blah. You collect about 100 data points in a few seconds, and the computer translates, and you're good to go. So once you had your data points, you see here, it's they kind of went all over the arch. So you have your data points, you registered the patient, you calibrated your tools, you can start tracking, and you can actually start your surgery. So with this, not even having to make the guide, your surgical preparation time is even shorter. And we have, I think this is unpublished data, but we actually looked at the comparison between the fiducial tracking and the tracking, just the one I have shown you here, and they seem to be exactly the same accurate. So that's good. So when it comes to the workflow then, first you scan the patient. and you have a standard CBCT or a CT scan, usually they recommend that you have a nice thin slice thickness just to make sure that the picture is not too fuzzy, because obviously the clearer the CT image, the better your navigation is going to be, because the better the computer is going to find your structures. Then you're going to look at your DICOMs and you export the DICOM files to the navigation computer. Then you are going to plan your teeth. You know, you can, just like before, wait, I have to get back to my marker if I can. There you go. So I just wanted to show you that just like with any other program, you know, you can place your virtual crowns, you can place your implants, you can look at it in 3D, you can mark the inferior alveolar nerve for future reference. So it's a very simple system. It's not going to, you know, the Navidan specifically is reasonably simple, which I actually liked about it. But you can plan everything. You can add an intraoral scan if you wanted to, if you want to get even more surface resolution, and then you mark your little landmarks for the tracing. And once that's done, I've done this before. Once that's done, you just put the tracker on the patient, and that's kind of like this. Usually you just use some kind of composite material, no etching required, because obviously you're going to remove this after the surgery. And then you mark your data points where you can see it on the screen, you know, where you're going to touch the teeth. And then you see that little ball burnisher in the right-hand side. You're just going to go through a couple of surfaces to make sure that the computer can relate your CBCT to the patient's mouth, right? And while you're doing this, it's extremely important that both the tracer and the jaw tracker are visible. Again, it took about, you know, 10 seconds, not a major issue. And once that's done, you can start your surgery. And this is the actual surgical window. And why this is fun, for all kinds of reasons, but why this is fun is because here you can see what the computer sees, right? So as long as the computer recognizes both the tracker and the drill marker, you're good. If something is not right, the navigation disappears, right? Also, you see that you can see the panoramic view, you can see all kinds of frontal, sagittal, whichever sections you want. This one here in the middle is the depth marker. So this is the one where you can see how far to depth you are, and obviously when you get here, that would be the end of your navigation. On the image here, the green is going to be your drill, the yellow is the planned implant position, and here you can see, you know, you can see up here both the horizontal discrepancy that you have from your plant position, that would be the bullseye, right? So here you see that the person is 0.2 millimeters off sideways, 0.2 degrees off in angulation from the planned, and you can see the depth that you are at the moment. And I found that this is kind of the trickiest part of navigation, because we're all human beings and we want to be perfect, right? So if you have a bullseye, you want to be on that bullseye, and you are kind of trying to like, oh, I'm 0.2 millimeters off, let's move it a bit this way and that way. And it's very easy to make a funnel out of an implant osteotomy just because you're trying to correct your wrist all the time, right? So what I found is the easiest is just to go and commit. Even if you're 0.2 millimeters off, you know, it looks like a lot on the screen, but what really is 0.2 millimeters in real life? Not much. Neither is 0.2 degrees, right? So you have to commit and you have to go with it, even if you are tiny. I mean, you know, if you're 3 millimeters off, that's different, but probably then you're not going to start the surgery. So you can see here that, you know, everything is moving. And of course, you know, if you come in and out as you're supposed to a little bit, then everything is moving in and out as well. But you can see how the drill is actually getting slowly to depth, and it is going, hopefully, you know, within a 0.5 millimeter and within 1 degree to the planned position. So this is what you're looking at, right? Again, you are not really looking at your patient too much. You can, but very often you're actually looking at the implant, the screen, and you can see that now it turned yellow, turned red. I don't have the sound right now, but the red means that you have to stop because you're at depth, and this is it. If you want, you can recalibrate your next spur and you can prepare the next step in your osteotomy. So It's actually really simple. I wanted to show you this one as well. For the tracing, it's actually possible not to fix anything on the maxilla because the maxilla is fixed to the skull. So Navidan has this somewhat alien looking contraption that is actually connected to a glasses and almost like a headset arch. And they just put this on the patient, and this is going to be the tracker for the patient's maxilla because, you know, the teeth don't move in comparison to the skull. So if you put something on the skull, then it works as well. This one was actually imported from the ENT surgeries because they use it for that as well. So this is how this system works, and you can see this is the setup, and here this kind of funky headgear is being used, and that's that. So if you look at the workflow and you think of, you know, the static guidance versus this tracker system, because as I said, most of the systems will probably use this very often or very, very soon. If you try to make a guide, which is a static guide, you have to somehow either make it in the laboratory or manufacture it yourself. Sometimes you even have to, you know, scan the patient with one of the guides, then you have to plan, and then once the guide is done, which sometimes takes a couple of days, that's when you can actually start your surgery. Whereas with navigation, by now you can skip through the guide. You just have to trace the patient. Even if the patient comes with a CT taken in a completely different office, you can still use it. And once you registered it with the tracing, you can start your surgery. So the whole thing takes less than an hour, and it doesn't really need any gadgetry other than, you know, the system, because and of course the trackers are all the same, even though they actually provide it for every single surgery because they don't want you to sterilize it and you know, distort it in any which ways. So it's very, very convenient and fast, right? And if you need to replan with dynamic navigation, that is a possibility. So let's look at a little bit at XGuide. It works exactly the same way. They also have the tracking. Now that they are with Nobel, they have a nice new spiffy video, and I tried to capture that for you. If it's not the best or you can't see it, I added the link so you can actually look at it afterwards. Or, you know, it's on the Nobel website. If you just Google XGuide, you're going to be able to see it as well. So there's a little bit of a video that shows their flow of system. And let's go with it. You see that it's the same tracking. You can mark the points and mark them in the patient's mouth. As long as the camera sees everything, you have your similar probe tool, but this is kind of the black and white markers that they use. If you want more points, you can actually do the refinement, and they have a slightly different navigation window, but it's kind of very, very similar. And you can see that their depth is actually kind of, and it goes around the circle. And that's that. So the systems are very, very similar, similar thought processes. You know, this one is more Nobel attached, and it's integrated with the DTX Studio. And Navidan actually has its own system, and it's completely open. And then I also wanted to show you there you go, this funny one, which is the mini Navidan, which has nothing to do with Navidan. This is actually a Swiss company, and their camera is attached to the handpiece, which I thought was a very interesting thought. You can see that this is actually the stereoptic camera, and they have their navigation marker on the patient, in the patient's mouth as well. I don't know, I've never actually seen how it works, so I'm not sure, but it's certainly an interesting concept. It's a lot, I mean, they still have a cart and whatnot, but I would just probably be worried about the visibility with the camera if my hands would get in the way, because you kind of have to learn to hold your hands in a way that it doesn't get in the way. So I'm not sure. I mean, time will tell. As said, they allied themselves with Straumann about 6 months ago. So maybe next time we meet, we can discuss this one as well. This is the next step, which is kind of interesting. This is Yomi. It's a robotic, half robotic system. It's kind of like the same as the navigation systems I have shown you, except it has this huge, bulky robotic arm. So you are still holding the drill bit, but if you are trying to go the wrong way, you're not getting an electric zap, but you know the arm is going to hold against you, right? So this is actually physically trying to guide you, not just via the computer screen. So this is giving you limitations as to how far you can drill, which makes probably again dexterity a little bit less important, and it gives you a bit of a help just to make sure that you arrive at the right spot. As far as I know, this is a quite expensive system. I haven't heard a lot of people who used it, although I think there's a university in the United States who was brave enough to install it. I'm not sure, you know, we're all dentists and we have dexterity, so I'm not sure how important this really is. But again, time will tell. And then I wanted to talk a little bit about accuracy, because gadgetry is fun, but it really has to have some kind of a meaning to it, right? So this is what I have also done my master's study on. And I looked at how accurate is my implant placement with the different systems. And what we usually look at is the deviation horizontally at the cortical area, so at the entry site. You usually look at the deviation at the apex, and then of course you want to look at the vertical deviation and the axis differences. And this is the Throwback Tuesday today. So this is me about 10 years ago, and this is me starting my master's project. And I thought it was actually looking at the accuracy of the Navidan system. Little did I know that it didn't exist, as in it did exist, but it was very choppy and it didn't really work. And you can see this is actually the owner of the company, an engineer, and this is the software engineer. So the three of us embarked and tried to make sure that this machine actually worked. And I can tell you, I was very frustrated in the beginning and I almost chucked it in the corner several times. And you see, this is also why everything looks different, because this is the early prototype, right? And then once the system was somewhat stable, we started looking at the accuracy, and you know, this was the setup. You see, there's no spiffy card, there's no spiffy anything. So you can, this is the camera, the light is different. There is only a little bit of a, you know, kind of like a tablet-like monitor. So it was very, very different, but the trackers are different. Everything is different, but we actually managed to stabilize the system enough that I could look at the accuracy. And we eventually, you know, after I got my results, I had my paper published that it was reasonable. We started using it on patients. And I don't know, you know, I don't know how many osteotomies I drilled with this thing, but let me tell you, it was in the couple of hundreds. So my results, I don't know, I hope you're not seeing this, but let's try to close this. So my results were reasonable. I actually took a lab fabricated guide. I took the Straumann guide. I took the Implant guide. I took the Nobel guide, and then I took the Navidan, and I compared the accuracy for all of them. And if you look at the numbers in general, you know, they are fairly similar all over the place. But, and I wasn't the only one drilling. I also had some colleagues who helped me, just so that it's not my dexterity all the time. We had some outliers, and we didn't have a lot of them, but sometimes we had outliers that were a few millimeters apart, and not just with the laboratory guide, even with guided surgery, because I really pushed the system to the limits. I only had 3 teeth. 1 molar and 2 canines, right? So I had a huge distal end. I didn't have a lot of teeth to secure the guides on. And sometimes pushing, pulling, shoving, we actually had millimeters worth of differences, right? So you have to be mindful that the systems work on average really, really well and within the 1 to 1.5 millimeter range that we expect from them. Axis deviation, again, it was very, very similar across the systems except the laboratory guide, because that was literally freehand surgery. So you can see that everything is really good on averages, but there are outliers. So you really have to be there mentally. You can't just 100% trust these machines. And this is just, I just showed you, this is an image when we first started using the system. The yellow was the plant position. The blue one was the position actually where we ended up. This one was a little bit deeper because we actually wanted to have better primary stability. So that was on purpose. And then, just a couple of results. You can see that you plan nicely, and then you place your implant. And if all goes well, then everything ends up exactly where you wanted it to be. And I wanted to show you a couple of papers from the literature, what people think today and what has been published. You have to keep in mind, as I said, it's not only manual errors of the camera, even CBCTs may have, up to 1 millimeter errors. So you have to be mindful of all these factors that will affect your accuracy, right? There have been several review papers out by now, not only on static and dynamic guidance, but even on robotics and technology. Most of them, if you look at it, on average, have very, very similar accuracy, which is all within the acceptable range, right? If you look at Ali Takmaseb's review, again, everything is reasonable. They usually say that static accuracy is more accurate, but most of those papers were actually published on in vitro systems, and dynamic was looked at in vivo. I mean, my paper was in vitro as well, but the point is that in vivo, everything is a little bit less accurate than in vitro, and they are perfectly comparable. Again, this is a paper where they looked at the usability, the ergonomics, and it's pretty much what I have presented in that table for you. That it's great, it's adaptive if you get used to it, because there is a steep learning curve. This one, another one. Everybody says it's great, it's promising. We need to do it more to actually use it to its full potential. This one was an interesting paper that has come out of a gentleman from Italy, from Dr. Stefanelli, who started using the Navidan system very early on. He was a very early adapter. And he has actually published a paper on 231 implants placed with the Navidan system. He also does it, the Edentulous, dentate, whatever else you want. And you can see that this is all clinical results. You can see that his accuracy is actually very, very good. But what I really liked about this is that he showed you that he did have a learning curve as well. So this is an experienced implant surgeon, but placing the first 50 implants and the last 50 implants, the accuracy is not major, but you can see that there is actually a learning curve for him as well. And the last 50 implants were much more accurate than the first 50 implants. So just kind of fun. This is Dr. Bloch's paper. He is using the XNAV system, and you can again see if you had fully guided implant placement, meaning you even calibrated the implant and placed the implant guided with these systems, you achieved excellent accuracy, right? Again, it's in the sub-millimeter zone. This is on the EPES, the Taiwanese system. Again, if you look at static versus dynamic guidance, pretty much the same values over the board. So I don't really want to further emphasize this, but you can see that dynamic navigation is at least as good as it would be with the static guidance, if we want to take that as a gold standard. This was a meta-analysis that was published, I think, last year, and you can see that again, dynamic navigation was much better than freehand, which is kind of a given, and it was very, very similar between static guidance and dynamic guidance. And that brings us to the future, right? So, I mean, as a society of people, we are really, really trying to get things smaller and smaller. I mean, you know, especially, you know, in countries like Japan and more digitally, you know, digitally focused nations, everything is getting smaller and smaller and smaller until maybe at some point we actually make it disappear. And in dentistry, that means that we are getting to virtual technologies, right? Or enhanced realities. And when it comes to augmented reality, you know, what happens, you have the patient and then you have the dentist. And instead of having a huge system and the cart, you actually have all of that, hopefully in some kind of, you know, Microsoft glasses or Google HoloLens or something like that. To my knowledge, none of those systems are really strong enough yet to really carry these systems without a little bit of crackling and a little bit of lag. I might be wrong. It might have jumped forward a lot, but you know, eventually this is coming as well, where you don't even need those big cards, but you can actually just have the overview in your HoloLenses. And this is really kind of the future. And this one was you can see the trackers. This one was done with the Navidan system, but it was connected to a robot. So you see people around, but they were mostly doing the suctioning. They also did the planning, and this is all from China. It has been published. They actually placed the implant completely robotized, so no human help whatsoever. And you can see it's to me this is a little bit scary, but you know, to each their own. So you can see that the robot is kind of getting closer to the person, and probably they were watching big time just to make sure that everything is fine. But this is all done by robots without human interference. So, you know, they looked at the stability. This is the, you know, the ISQ value. If you look at their results, it actually is also very comparable. They have very little sub-millimeter deviation. Is this the future? I don't know. I mean, if everything is straightforward, possibly. If everything is not straightforward, I think still we need our noggins. And if you want to see sci-fi in the future, you can see that, you know, that's where we are going. You have dentronics, you have artificial intelligence, you have micro-robotic tools. Feel free, you know, if you want to see some interesting stuff, read these papers. This is where we are going, you know, where computers are going to tell you if there's caries on an X-ray or not, or, you know, it's going to see if there's a canal or a fracture in a root. It's going that way. We can't really slow this down. And with that, I wanted to give you my key points. Let's get back to the now, not necessarily robotics and future. I hope that I managed to impress upon you that dynamic navigation is flexible and it's very visual. It is as accurate as any other system that we have on the market right now. It is easier to do the surgery because nothing really is in the way of your surgery. However, you have to get used to a completely different line of sight. You have to make sure that you are not in front of cameras. You have to make sure that you actually have a good dexterity because the machine is not really helping you. And patience, because it takes some time until you get really well versed in these systems and, you know, your hands get used to it. And with that, a final warning that, you know, no matter what we do, machines are just machines. And sometimes, you know, you can have a power outage. Sometimes the machine can be wrong as well. So you cannot really just 100% trust these machines. You have to have the surgical skills and the theoretical knowledge to place implants and to place them well, just in case. And with that, I'd like to thank you for your attention. And if you have any questions, I think I see that there are some questions. I'll try to answer them. But if you have any other questions, please send me an email and I'll be happy to answer them that way as well. So thank you very much for your attention.
Thank you so much. Let me just share mine. Thank you so much, Esther. It was very, very inspiring lecture. I really myself like it because you touched in different important aspects. You dived with us back to the hand-free surgery and how they started to do implants with the hand-free surgery. Then you go and show us how dynamic and static surgery for the implant is enhanced with extra technologies that involved to improve the outcome of the surgery. And you extensively compared between the dynamic and the static, and I can see the really promising results that comes out from the dynamic surgery and how the surgery is enhanced with less complicated procedures on time. And then you fly us higher to the future of the implant surgery with using the robotics and what can be done in the future. So thank you so much for that. Yes, you are right. We do have some questions. So I think we have two questions from Dr. Wang. So first, Dr. Wang, thank you for your wonderful lecture. For her first question, did you compare the surgery time used between using navigation and static guides?
Well, I didn't compare the time, but there are several papers out there that did compare the time. And I think just like everything in the beginning, if you're a beginner at navigation, then, you know, the whole setup and the whole calibration and the whole process is going to take, you know, probably the same amount of time, maybe a little bit longer. But once you get used to it, I would think it's actually a little bit faster because no, actually, I'm not sure, because if you have your static guide seated and everything is fine, and then the only thing you have to do is just change burrs and then go up and down, then probably in that sense, you know, the surgical procedure itself might take a couple of minutes less, right? Because with the navigation, you have to calibrate whenever you change a burr, which takes about, you know, 5 seconds or 10 seconds. So it's probably as many times you change a burr times 5 to 10 seconds that your navigation is going to be longer, right? So it's not, I don't think it's a considerable difference. With the overall time, I think I addressed that you know, just for the preparation, it is going to be a lot shorter for navigation because you don't need the guide itself. You don't have to manufacture the guide itself. And thank you for your question. Is it okay if I go forward with the second question, because I can actually
please. Yeah.
So the second question is how you use navigation in fully edentulous patients. So usually what happens is what they take those trackers that have the fiducial markers on them, they just use a mini implant, you know, like a tack, and they actually attach it to the patient's jaw. For the upper jaw, it's not an issue because you can use that, you know, futuristic alien-like glasses, and maxilla is already taken care of. It doesn't matter if it's dentate or edentulous. Because, you know, if you want, you can actually register the alveolar bone if you want, once you flapped, or if you don't flap still, you know, they use this system in ear, nose, and throat surgeries as well. And there they actually they use the nose and the eyebrows as navigation points because those are, you know, relatively hard and they don't squish too much. And the system is going to be able to calibrate with soft tissues as well. But for the mandible, you do have to, for an edentulous patient, you do have to have a mini implant and tack the fiducial marker in place. And then you go ahead as before. So I think there, dynamic navigation really has an advantage, because if you think about the surgical guides that you either put on the mucosa and then, you know, you're doing everything flapless, or you have to flap everything big time so that you can actually have the guide sitting on the bone itself. Either, you know, it's quite a bit of comorbidity, and also, I mean, if you look at the literature, the evidence shows that the static guides are least accurate on fully edentulous patients because of these changes. So I think dynamic navigation is definitely superior in fully edentulous patients. Thank you very much for your questions, Tom Mayen. Nice to see you.
Thank you, Eszter. Eszter, you mentioned in the last slide is that whatever technology is bring to us, it's still a technology and machines, and human touch is still very important to deliver any treatment process for the patients. But in terms of manpower, and the robotics can do many tasks in a shorter time. So how do you see our provision in that direction? Can you touch on that, please?
Yeah, you know what? It's I'm not an expert in artificial intelligence, but last year I actually listened to a lecture given by one, and the way we imagine artificial intelligence and thinking of robots and cyborgs and God knows what, who know everything and behave like humans, we are still very far from there, and we are far from there because the human intelligence can do things that even with training for robots or artificial intelligence, it's difficult. So, for instance, like silly things that you think of a human, and if I see you, I will, whether you laugh, you are grumpy, you cry, or you are tanned or not tanned, I'll still know that it's you. But for a computer, for instance, recognizing facial expressions, they don't necessarily know that that's the same person, right? So little things like this, or a poodle that has like brown wavy fur versus a person who has brown wavy hair, the computer cannot always tell that one is a poodle and the other one is a human being, right? Because it looks at hair, both of them are fine. So either both of them are dogs or both of them are humans, but there's no difference. So this is why, when you do all your dental training and you actually know that, let's say, and I get back to caries because I know there are a lot of AI systems out there that are recognizing, implant systems, because sometimes you have these implants walk into your office, you have no clue what it is, right? So they're working on implant system recognition AI systems. They're working on X-ray analyzing AI systems where you look at caries and the machine will be able to tell you what it is and what it is not. So, I still think that the human intuition, so to say, and I'm, probably there is going to be coming a time where objective decisions can be made better by computers. Like, is it carious, is it not carious, black, white, pixel, fine, you can do that. But when it comes to higher intelligence things like treatment planning or deciding if an abutment is going to have a better outcome or worse outcome. So I think there's still things that maybe I'm wrong, I might eat my hat and my words in 10 years, but right now I think where we are at with artificial intelligence, I don't think that they have the human creativity in them that we need for dentistry just right now. And what was interesting is that, listening to this expert's lecture, he actually looked at professions that will be replaced by computers in the next 10 years. And, like real estate agents was number one, cashiers in stores, which is already happening anyway, number two. So there's a lot of professions that will not be needed because computers can do all the work. He stated that he didn't think that either dentistry or medicine will be able to be replaced by computers because we still need that human creativity and thoughtfulness in there. I hope that's somewhat encouraging.
Yeah, you're true, and you're right. Yes, the human touch, human interact is very important, especially for the final decision. But I guess with the AI, the most important thing that is the possibility to analyze and provide the huge data that can be done in a matter of seconds. And that will help for the decision making for the surgeons, for the prosthodontists, and will make the workflow more efficient with those feedback. The super fast feedback informations, either visually or physically. So there are many possibilities that the near future hold for us. So we are looking forward to see what the next step that we can see. And we are fortunate we are still within this revolution that we can see those huge change in our profession. So with that, Eszter, I would like to thank you for your time and effort. You provided us with very interesting and inspiring information about the digitally enhanced implant surgery. So before that, it's our tradition. We would like to hand you the certificate of appreciation. So we hereby express our sincere appreciation to Dr. Eszter Semogy-Ganss in recognition of her contribution as a live webinar speaker for the Digitodontics webinar series and the topic of digitally enhanced implant surgery that was presented on Tuesday, July 12, 2022. So Eszter, thank you so much. And also I'd like to thank all the attendees who spent their time to attend this very important lecture. So thank you all. And if you have any words, please do so, Eszter.
No, thank you. Thank you so much for your invitation. It was my pleasure to come and present. And I guess I'll wish everybody a great day. Thank you so much for listening to me.
Thank you. So we come to the conclude our webinar today. Please stay tuned for the next upcoming webinars. We have a number of webinars that will add to your knowledge in digital dentistry. So please stay there, and you will see all the new in digital dentistry. So thank you so much all, and have a nice day, evening, and everything. Thank you.
Thank you.
Bye-bye.